better if we don't get feedback, but that'll be fun. It's that's people's iPhones. Okay. We haven't made much progress. These are the 1 year age-specific data. I don't know where you want me to stand to get away from the microphone. These are the 1 year data. And what it tells you is, again, what Paolo said, that migraine is a disorder of productive years. Whether you think about it as the people who are holding society up, or you think about it as, I say to regulatory people, as a disorder of taxpayers, migraine is a huge problem in the community, and that's fairly obvious. The burden is really substantial. Of course, the burden falls substantially on women in their most productive years. Well, I would be careful what I say, but what I'm talking about in terms of tax and regulation, I realise people are productive into later life. You will probably see I've done a number of courses. In the population, this estimate of 12% is clearly wrong. It's clearly wrong. It's done by best intention, questionnaire studies and so forth, but all of you in clinical practice realise that a questionnaire underestimates things because you don't get the chance to really get a history from a questionnaire. So 12% is unquestionably an underestimate. So a huge population of people. And in neurology, these are some data from the UK. British neurologists live in a state of denial. They think that they look after people with Parkinson's disease, but hardly ever walks in their room. They think that they need to be really interested in multiple sclerosis, and it is an interesting problem. But you add them together, and it's not even close to what's walking in with migraine. So unquestionably, we need to be learning and teaching, those of us in teaching jobs, teaching people about how to manage migraine, because it's unquestionably the common thing that comes in. And the last data point I want to show you, it's a really important study that Stu Tepper led on several years ago, which forms some of the data for saying that what I just said, that most of what walks in is migraine. This is a so-called landmark study that showed if you take people who come to see a doctor who've had headache problems for 3 months, a GP in the US, and you give them a diary and then you get experts to review the diary, that more than 90% of them will have migraine or a migrainous headache, missing one of the criteria. So if you think that you've got more than, say, 5% of people coming to see you with tension-type headache, there's two possibilities. One is you've got a very unique practice in the entire world, or you're wrong. I'm going to give you the news, you're probably wrong. Most of what's coming to see us with disabling headache is migraine. Some of it's been mislabelled, and the classification committees, it's not that the classification's wrong, but it wasn't designed for clinical practice the way we apply it in a diagnostic sense. It's designed much more for a research purpose in that way. We could talk about that. It's a little bit of a small area. So, where are we in some of the pathophysiological things? Migraine's complex. Okay. It's not just a pain problem. It's a very bad way of thinking about it. It's a complex brain disorder, reflected by the premonitory and prodromal phase, the complex things that happen in that, pain unquestionably, and sensory sensitivity, the attacks. And migraine is a disorder of, as I show here, of repeated attacks. Either, we call it episodic and chronic, but of course the 15-day rule is completely ridiculous. Ridiculous. I don't even know why I signed up to it, because it applies a line in the sand, which in Egypt sounds like an interesting idea. Sand, Egypt, come on. Okay? In the UK they call it a pun, clearly not here. Family history is important in migraine, and of course the much vaunted triggers, much of which I think have been overemphasised and maybe better re-examined and thought about in the context of the premonitory phase. And I might return to talk a little bit about that. On a pain level, our understanding of the pain mechanisms is reasonably clear-cut. There are trigeminal afferents, illustrated here, that descend down to about the level of C2, cervical 2, so this trigeminocervical complex, and the inputs that come from the cervical system and and feed into the same neurons. The crucial thing that you can establish from experimental work, I think from clinical work, is that whether the pain's at the back or pain's at the front, it's going through the same group of neurons. And this trigeminocervical concept very easily explains the presentation of patients with pain all around their head or any distribution that you like. An important principle here is that this system was not designed for localization. It's designed for warning. So it can be severe, but it's diffuse. It's not designed to take your hand off the fire. It's designed to warn you that something's happening. So using it for localization is not a good idea from an anatomical perspective. And of course, as we've understood the transmitter systems within the trigemino-autonomic reflex, here I've illustrated, it's become really obvious that neuropeptide transmitters are important in this system, manufactured in the trigeminal ganglion, calcitonin gene-related peptide, and pituitary adenylate cyclase activating peptide, and PACAP and others in the sphenopalatine system. And this trigeminal and parasympathetic autonomic outflow is the fundamental wiring system, as Lars Edvindsen pointed out, in understanding head pain mechanisms. So you can pick on any particular symptom and understand it that way. Now, specifically, it's been clear for a while that CGRP is an important transmitter both peripherally and in the trigeminocervical complex, here illustrated really nicely by some human work of one of Lars's PhD students. So I had the pleasure of reading and examining the PhD some years ago. And CGRP co-localizes with tryptan receptors. And we've been interested for a long time, I think, in trying to understand whether you could, whether you necessarily had to constrict blood vessels to control migraine. I think not. The evidence is crystal clear now, not. To regard migraine as a vascular problem, vascular-driven problem, is just untenable, I think, from the data that we now have. The CGRP story is, I hesitate to say it's an old story, because that would mean that we were old, but we don't think of ourselves as old, so it's a mature story, I'm coming to say. Lars and I concocted some experiments in the mid-1980s to test the question around whether you could translate neuropeptide changes from trigeminal ganglion stimulation into humans, and could, here, CGRP and substance P, and then to go on and test if you hone down the model systems we were using into the trigeminocervical, trigeminovascular system, nociceptive afferents, what would happen. And we predicted indeed the failure of the substance P drugs, and they indeed did fail, and then showed that CGRP was released in migraine, and this you could normalise it with a tryptan. And I think it's fair to say that set the stage for what became the CGRP hypothesis that's now generated these new medicines. Olson, ever sceptical of things, you might say, tested this in the human models, and they've got some very good systems for doing that, and was able to trigger migraine, what they call migraine-like headaches, by infusing CGRP in that study. This is the road test of what's happening. What I want to provide for you is a kind of back structure for a lot of the discussion that you're going to hear in the next couple of years around this. The first test of this hypothesis was this study, intravenous CGRP receptor antagonist called olcedupan, that was published in the New England Journals, clearly effective pain-free given intravenously. These are the oral medicines that were tested, telcagepant, 44370, rimagepant, 3207 and ubrogepant. The only ones that are still in clinical development are rimagepant and ubrogepant. And clearly all of these were positive. There's never been a negative study with CGRPs either in the acute treatment, which I'm showing you here, all of these phase 2 studies, or with the preventive strategies, which is quite something to say. You won't be able to escape, if you're even vaguely interested in headache in the next 5 years, you won't be able to escape talking about CGRPs and CGRP receptors and so forth. So it doesn't hurt to re-emphasise this a little bit, because you need to understand it. It's all over the blogosphere, and it'll be all over your clinical practices. CGRP is a 37 amino acid peptide. It's on chromosome 11. There are two genes. One drives alpha CGRP, the other one drives the enteric beta CGRPs. 3 amino acids different. For all of the treatments we're going to talk about, they don't distinguish between those differences. Now, the CGRP receptor itself is a really very smart way of doing things, if I could put it that way. It's formed by a classic 7-transmembrane G protein coupled receptor, like a beta receptor, same sort of broad structure, you might say. And its specificity is driven by what sits on the surface with that, these so-called receptor activity modifying proteins, or RAMPs. So, for an example, if the calcitonin receptor sits up there, then fortunately it's just a receptor for calcitonin. Okay. The other receptor, which is like the calcitonin receptor, is called the calcitonin-like receptor, because it's like the calcitonin receptor. It's not very creative. And if it's sitting on the cell surface with ramp 1, and there's 3 of these ramps, then CGRP will turn it on. It's possible as a second receptor. I haven't seen anything convincing in vivo about this, or indeed certainly in humans. But it's possible as a second receptor when the calcitonin receptor sits with ramp 1, what is the amylin receptor. This is unclear. So we may get out of this pretty easy clinically. It just may be one receptor, and that would be very cool. This is what we're doing currently with prevention. So it's clear from the physiology, if you want, migraine's a brain problem. It's clear you don't have to constrict blood vessels, and it's clear that there's a large unmet need in terms of treatment. This is some of what's used. If your favourite preventive is not on the list here, then my apologies. And if you don't like the way I've put them together, it's just a sort of neurological ordering system. But I wouldn't get into a pitched battle about any of it. And the problem with this list is there is no theme, really. It's a theme of serendipity, which is not a bad thing, but serendipity doesn't often not provide fundamental understanding unless you can dig it out. And these drugs are largely dirty, and you know that from your clinical practice, all of you who've ever used topiramate and had the patient come along and stare at you blankly. And that's all they say. I tell my clinical fellows, if someone comes in and you ask them a few questions and they're irritating you by the slowness of their answers, chances are they're on topiramate. I don't like it very much. So what's happening with the CGRPs? I'm going to present you some summary data from across the phase 3 studies. I'm going to use the 50% responder rates because I find that easy for communicating to patients. So this is the number of patients who have a 50% reduction in their migraine days. It's an easy number, and I'll go on to the 75% in a second. So the first thing to say is these are all phase 3 studies. There are, and 3 of these are now licensed in the US, 2 are licensed in Europe. The 2 licensed in Europe are erenumab and galcanezumab, and erenumab, galcanezumab and fremonizumab are licensed in the US, and soon we'll have eptinizumab, and then you'll need to be able to run off your tongue eptinizumab, erenumab, galcanezumab and fremonizumab, or if you want to say fremonizumab, galcanezumab, or eptinizumab and erenumab, in any order that you like. And if you can say them in any order at all very quickly, you've learnt it all. The structure of the name, if you want to understand that, MAB means monoclonal antibody, U means human, N means neuronal. That's the structure of the names. Z means humanised, and without the Z means human. So the naming system is mandated in that way. How the other parts come is a matter of taste. All of these are significant against placebo. That's crystal clear. I tell patients that about 50% of you will get a 50% reduction. It's very important with these medicines, I'll say this right now, because there's been so much hype around them, to dial people's expectations back a bit. Migraine patients want a cure. This is not a cure. We don't have a cure yet. Maybe we'll get one, it'd be nice, but we don't have one. So some of these patients who get these new treatments are going to be incredibly happy. Some are not going to be happy. But I find it useful in practice to start out with dialing it down a little bit, because you'll get less people being incredibly unhappy if you do it that way. These are the 75% responder rates from the randomised controlled trials or from abstracts. Much of this is still only in abstract form because these data are quite new. My impression is that when people get a 75% response rate, no matter what it is that you're doing, they're actually quite happy. That's a pretty good place to be. Now, in the chronic pain world, they think 30% is okay. Good luck to them. And 50% is a good marker. But 75% is where I think loyalty starts to play. Obviously, people get 100% response will get that. And I quote patients more or less at about a third again, 25% to a third will get that. And these are for episodic migraine. Now, most of you will say, okay, fine. Where's the chronic migraine data? And I'll show it to you here. Although I have to say that the idea that people with 12 or 13 or 10 days a month don't have a really serious problem, I don't get that at all. That's going to be a work in progress to discuss. These are the chronic migraine 50% data taken from across a range of studies. And what I put in here for comparison, so the dotted line, really, these are not direct studies, and I've cited it all down here. Be very careful about this. These are what's published. And what I want to show you is the placebo rates. Eptinizumab's given intravenously probably drives the placebo rate up because of expectation. And these are for the monoclonal antibodies, Renumab, Fremonizumab and Galcanizumab, and botulinum toxin from the preempt meta-analysis migraine day endpoint that Sheena Aurora published and led on, and then Steve Silberstein, the topiramate chronic migraine study. It's unquestionably true in the chronic migraine space that the placebo rates across the subcutaneous MABs are no greater than the placebo rates for what you know. Is anyone who says that's just can't read or count? And it's unquestionably true that the therapeutic gains across the subcutaneous ones are no less than what you currently have. Let's read the data. It's unquestionably true that these medicines are not going to fix everybody, and unquestionably true that they're going to be useful for some people. And here's the 75% data. Again, I've had to dig this out a little bit. Some of it's phase 2 data because it's not as easy to extract. But I think you're going to see the same sort of theme as I move across here, looking at the therapeutic gains. And there's some Botox data from from the presentation Dave Dodig did at a meeting some years ago, just to give you some context. 75% people are really happy, I think, really happy. An important other question, which we've begun to dig into, is what happens if you failed previous preventives. What I just showed you is a mix of people. Obviously, most of the chronic migraine patients had previous preventives. A retrospective look at what happened in the STRIVE studies, one of the Erenumab phase 3 studies in episodic migraine, showed something which probably we should have realised, but we didn't. Now, I'm as guilty as anybody else for suggesting that people who'd failed multiple preventives might be somehow more difficult to treat. Everyone's kind of maybe that's true. It turns out that from a clinical trial perspective, they're really good patients, because people who've had previous failures seem to have less expectation. Their placebo rate's lower. So the odds ratio for placebo and active goes up, and it's easier to demonstrate differences. We clearly got that wrong. The other thing is that clearly the first tranche of people you might want to treat with these new medicines are going to be people who failed preventives. And so this study has just gone into press about a week ago in The Lancet, and it's been abstracted at various meetings, the so-called Liberty study, again with this 140 milligrams of Renumab. These are people who failed between 2 and 4 preventives. 3/4 of them had failed topiramate, just to give you context. About a third had failed amitriptyline. About a third had failed propranolol. So these are drugs that you know and no doubt the patients don't love. And what's clearly true, as you get good odds ratios, they hold up as they have for the broader RCT, phase 3 RCTs with active treatment compared to placebo. We can clearly treat these people who failed multiple preventives. That's great for patients. Earlier discussion, there was an earlier discussion about adverse events with these medicines, and I think that it's fair to say that maybe no two people in the world feel more paranoid than Lars and I about whether something will go wrong. But nothing's gone wrong so far, so we're feeling okay. Because we'd hate to be responsible for something going wrong big time, and we don't think it will, so we're doing okay. These are interesting data. An important thing here is that much that we know about the role of CGRP in chronic, in that chronic sense that's negative has come from rat studies. It's very important. So you have to road test a lot of these statements in humans. It's clear across the controlled trials that have been done, there are no blood pressure and heart rate changes. I'm talking about across 10,000 people in these studies. That doesn't happen. So the fact that that might happen in rats doesn't bother me at all. I can live with that. There are no ECG changes. Nothing's happened on liver enzymes. Liver enzyme problem with telcagipant was certainly, I think we can say, a metabolite of telcagipant rather than a mechanism-based problem. So that's clear. Injection site reactions, yeah, you do see those. Some of the patients get these irritations. Some of them are a little bit larger, actually. I have to say we've seen that in practice. The biggest concern, I have to tell you, with people who get the injection site reactions is that I might stop them getting their next injection. I haven't had a single person yet who said, I want to stop the injections. Rather, I want to continue them because I'm worried you're going to stop them. So it is what it is. In the studies, 3% of patients got constipation. That seems more common in the US these days. I'm slightly cynical about whether if you tell people they're going to have something that's a little bit more than it otherwise might be. That's a complex thing. The anti-drug antibodies haven't proved to be a problem, and the neutralising antibodies don't provide any efficacy issues. Another important thing which comes up from the last discussion is the FC component of these receptors has been glyco-engineered so it doesn't interact with the immune system. There is zero concern about immune modulation simply because the immune end of these antibodies is not active. It's at zero. What they are is immunopharmacology at the FAB end, not immune modulation. It's an entirely different concept, and it's a bit something we have to grasp. So none of that immune problem that's come in MS is just not relevant because it doesn't come to the biology. And as Lars said, there's been no tumour issues, and you wouldn't expect them because the immunopharmacology is very much about it does what it says on the jar. It goes after the ligand and the receptor. Speaking to people who just thinking, those of you who are in training or just started your neurology career for a moment, why are you in neurology? Because you're interested in improving problems for people with brain disorders. Okay, that's true. Migraine is a brain disease. That's true. And the combination of understanding a complex brain disorder and increasingly be able to use that understanding to make people better, that's why you want to be a neurologist. And that's what headache offers. What I guarantee you is that the therapies we have now and we're growing, we're going to have more. There's more things in the pipeline. So what I guarantee you, if you're a young person thinking about what to do, you'll be so happy if you get into headache now. You'll be so happy. And if you don't, you're going to be sad because you're going to have missed the greatest opportunity of your generation to get into headache, get into migraine and make a real difference. So if you haven't made up your mind yet, if you're crazy enough to go into something else like neuromuscular or something like that, I'm sorry for you. But stop You're on the road, just stop and get into headache, because we're going to make a whole lot of people better in the next 15 to 20 years, and you can all be part of it. Thanks very much.
Thank you very much, Professor Peter. Of course, a very lovely talk as usual. And let me just ask you a question to start. Is, in your opinion, is the CGRP changes in migraine, are they universal across all patient populations? Or, so for example, in the Egyptian population, it's just physiologic that will be applied across all populations? Or
Yeah, that's an interesting question. Is the physiology, it's a broader question, isn't it? Is the physiology of migraine different? I don't think it is. I think that everywhere I've been in the world, and last time I was here was 1996, seems like yesterday. I haven't aged a bit, correct? No one's laughing, okay. And I came here when sumatriptan was first launched. I remember when it was first launched. I've never been in a country where where migraine phenotypes really are much different. When you look at a big picture, or that the therapies are really much different that are available. I would be really surprised if you saw any different overall rates, or you might have some adverse event issues of a minor nature. They might almost be cultural in what's described. I think this is going to be, I'd like to think actually, that it's a development that's going to just benefit the entire world of migraine patients. That might sound crazy, but certainly that's what Lars and I set out to do, so we kind of hope that's going to happen.
All right. Professor Bolai, would you like to comment on Peter's talk? Would like to see your opinion on whether you would like to comment on pathophysiology and current treatment options in the light of what Peter was saying.
I could ask a question, maybe. Is it the super responder people? Do they become non-responders? I mean, the 100% responsive patient could be non-responsive. So is it, variable, or if it is not, then could it be some genetic or, the pathophysiological changes in these patients?
And responders will vary. It would parallel the outcome that they saw in the controlled trials. They really haven't. Steve, you got a view? You've been in the trials.
50 to 60%, and why they don't work in the other. And one of the fascinating questions to me is the fact that if you look at Peter showed you, people who failed 2 drugs in this particular trial responded just as well if you look at the odds ratio. Migraine has a pathway, and there's bias. It's like having 2 roads. One road is doing most of the traffic, the other is clogged, or vice versa. And when CGRP is the dominant pathway, blocking it helps you. And when it's not the dominant pathway, the alternate helps you. And I think we need good biomarkers for CGRP activity, but the proof in the pudding will be when alternate antibodies are developed against other neuropeptides, will they show that there is CGRP and PACAP-related pathways.
I would like to, raise another question, that why we don't see, too much side effects when we block the CGRP, which is abundant all around the body, including skin, gastrointestinal system, and almost we see no side effects. What's wrong? Do we miss something?
Well, I think side effect-wise, you're right. It is extraordinary. I mean, there is 4 companies doing this development, and there's more than 10,000 people being exposed, and I don't know what the number is in the US. I'm sure it's north of 150,000 now who've been prescribed. And nothing really new is emerging. I think there'll be always a little bit of noise. I think that it speaks to redundancy. These neuropeptide systems are modulatory, and there are redundancies in the modulation. The most obvious one is the coronary one, where, for example, adrenomedallin seems more important than CGRP. Fine, okay, so lucky we didn't pick on adrenomedallin. I think there's redundancy, and the body is pretty good at getting around things if there's good redundancy. If you block all beta receptors, they're all over the joint. And you get side effects, but it doesn't sort of stop the body. So redundancy would be is the key word for me, and there's a lot of neuropeptide redundancy, and that's, I don't think we've missed anything. There's bound to be someone simple. And it's interesting clinically. You must have all had the conversation with the patient. You go to start them on, I don't know, amitriptyline, for example, and you start explaining to them about depression and blah, 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 and dry mouth and tiredness, etc., etc., etc. When you start to prescribe a monoclonal antibody, there's not much to say. Like, it's for migraine, it works in migraine, and that's it. It's a very, I found it a very funny conversation having so little to say. But yeah, redundancy, I think, is the answer.
But can you confidently say to the patient that it has no side effects? Absolutely.
I think what you can say, to be careful, at this point in time, with a large number of people being treated, we haven't come up with any side effects except for one, constipation. And I discovered there's actually a patent using monoclonal antibodies to CGRP for the treatment of intractable constipation. And the reason is that the way we move our bowels is CGRP, both in the muscle and the mucosa. But other than that, I agree with Peter, and it reminds me of the leptin-ghrelin system. We saw it where there's a hormone that regulates satiety, and we find that blocking it makes no difference, which again, I think with every neuropeptide in the body, there's a redundancy.
Got some people.
Questions from the audience?
I believe in clinical trials we are comparing the effect of drug CRP against other medications. So in real life, when I treat a patient, do I need to stop all other preventive medications to start this one, or we go head to head, and if there is an interaction between it and other medications like topiramate and others?
From a practical, open life point of view, in our practice, we probably have over 500 patients been treated with the antibodies. And it's the rule, not the exception, that every single patient is in another medication. Many clinical trials exclude coexistent medication. And the reason we always feared was if they're on one medicine, the second one won't work. And a good example was that of the trial we did with topiramate with that on placebo, didn't add. But if you look at one of the trials, they kept people on preventative medicine, it made no difference. So my bias has been, and there are purists where they stop things, my bias has always been the patient is doing fair, add a new medication to it, they do spectacularly eliminate the old one. But if you stop it, they may do horrible, and you may mask the effects of the new medicine.
It's a matter of your clinical practice. My practice has been, if something doesn't work very well, to stop it. I'm not scared to say that. It's a different clinical, it's a different approach, but it's not like there's right or wrong. With these medicines, there's certainly data for exposure to most of the things that you'd be using for prevention with them, and there's no interactions. So what I do is try and understand what the patient's looking for. If they don't like something and they're getting side effects on it, even if they're getting a modest effect, I get them off it, because migraine patients want to feel normal and they want to be on as few medicines as possible in my hands. So there's no right here. There's a little bit what's comfortable, because there are no interaction problems. So if a person's in love with the medicine and getting a 20% effect, maybe you can add a monoclonal on, and if they don't like it, and topiramate would be the great example, it's like brain Drano, then I very often get them off it. I have to say, my bias is to take people off things so the responses and what I get are clear, but that's a clinical practice bias. You should feel comfortable using this medicine because it doesn't have any interactions with any of the things that we usually use.
I agree. It's a matter of personal preference and bias. And the patient's doing fair or moderate, I add something. If they have side effects or not doing well at all, why keep it going?
Thank you, Professor, for your very nice presentation. After treatment, probably it needs repetition of the drugs, and for how frequent the drugs should be given. The other question is...
Just do one at a time because the acoustics is not very good, so I'll forget the first one. I think the question is whether these monoclonals are preventive.
Yeah. Is it preventive?
They're for preventive. Yes, they're designed as preventives. Their onset of action is quite quick. Some patients will see an effect within a week or two, which is quite remarkable. I don't say that too much because I don't want them ringing me in 2 weeks and telling me that they're not well. I don't have that's not a good idea. But the onset can be quite quick, but they're preventive medicines. There are new acute treatments being developed, but we haven't discussed any of those. These monoclonals are for preventive treatment.
The second question is for treatment of trigeminal neuralgia. How effective in treating this trigeminal neuralgia? And also, because I have a lot of cases with trigeminal neuralgia for that, because the standard treatments are they cannot eat their regular diets because of the pain. So how effective is treatment or preventive therapy or curative therapy for treatment of trigeminal neuralgia?
For trigeminal neuralgia? My bias is based on the nature of the pain, that it would not be very effective. It's a neuralgia, and my bias is the shorter and faster the pain is, the less likely a neuromodulator will be effective. And many people believe that most idiopathic trigeminal neuralgia is really due to pressure on the nerve at the root entry zone. So you need to think mechanistically, how would something that modulates CGRP at the A delta fibers work when something that's directly irritating the nerve fiber? We'll see. They're coexistent patients. I think that we have evidence now that it's beneficial for cluster headache. It's very curious to see if it works in the attacks. There seems to be a paradox. The shorter the drug is, the attack is, the different it is and behaves.
My question for Peter, I have 3 small questions. The first one is...
Just one at a time then.
The pictures you mentioned on your paper on 2002, the location on the brain in the migraine, has it something to do with what is partly called the spreading depression and the aura in migraine? Second question.
Yeah, let's talk about spreading depression. Well, you're as expert as I am. I'm in the camp that accepts that, broadly speaking, what happens in humans during typical aura is probably the same human version of what's happening in experimental animals during cortical spreading depression. There are a few wrinkles around that, but that's what you'd expect from the different structures of the brain. So that's where I am with that. I think that if you're asking me whether, in the CGRP context, the evidence is that if you go into a clinical trial with a diagnosis of migraine with aura, and the aura has been, you've had aura in the previous year, indeed in the previous month, then you're no less likely, or more likely, same likelihood, as someone with migraine without aura to respond to a monoclonal antibody. That's an evidential statement. Masuda Sheena presented that data at the American Academy this year. after that, we don't have any real data around monoclonal antibodies, specifically what they do to aura, because aura alone wasn't counted in any of the studies. I think that's a fair summary of the situation. Is that fair?
I have a second question about pregnancy.
It's a helpful thing for the human race, yeah.
So for the pregnant women, are these patients allowed? And third one about the price. I think
there
should be
a receptor that's responsible for the transport of antibodies from the mother to the fetus, called the neonatal fecal FC receptor. That's the same receptor that's responsible for the long half-life of the antibodies themselves. So there is preferential transport of all antibodies to mother to fetus. At this point in time, we don't know of any long-term safety studies of what the results of the pregnancies are. There's a few, so far they're negative. So my bias would be, until we have better evidence of the safety, not to use the drugs in a woman who is attempting to get pregnant. The other point is, with a small molecule, you can stop it and it's out of the body. With a monoclonal antibody, which hangs around for a month, which is the half-life, you may have to wait 4 or 5 months until the levels go down.
That's all true. It's also worth saying that in the first 8 weeks, that receptor is not well developed. And so there's relatively little transport of IgG in the first 8 weeks. That's reasonably well established. So if there's an accidental...
The antibody, because then you have another 2 months till it develops. If that worked correct, I would wait 6 months.
I would like to comment on the question of corticospecific depression thing. The CGRP receptor antagonist, which is bioavailable in experimental in rodents, we use this, and the drug itself, within 2 different dosages, did not inhibit cortical-spreading depression in the cortex, did not change cortical-spreading depression associated cerebrovascular, blood flow on the dura mater, but the same drug perfectly inhibited the pain behavior after cortical-spreading depression in the animal, and also the trigeminal nucleus caudalis activation. So drug, the CGRP receptor antagonists, even in the rat, probably they have some entrance to the CNS, but it's a very small amount, I guess. But they did not change the CST. Probably it's not going to affect the aura itself, but probably block the pain phase at the periphery.
Right. We'll keep the questions for later, but we want to do a small interview with a patient, a typical chronic migraine patient. It's a small interview, and then we'll see your opinions and see if the approach to treatment in such a patient. So we welcome Mr. Yahya. Please come in. Yeah. Chair, kursi. Kursi. So, هيك عاوزني طبعا أسألك بالعربي.
Thank you, Professor.
Okay. So I'll ask him in Arabic, and his son will translate the questions.
Should I try?
Yes, you can. Yeah. So I know you. You're my patient, but I will ask you just for the interest. How many years have you had migraine?
About 35 years. 35 years. He's 50 years old.
Right. And how much do you think you suffer from migraine?
He says that the effect it's dominating his life. The headache is dominating his life. It has a severe effect on his work and on social life. He's extremely sensitive to light. So, for example, in this room, this light would still affect him. He's very sensitive to sound, so he cannot put like a mobile phone on his ear. He has to speak on a speaker. So it's completely dominating his life, his work, his social, everything.
Right.
Okay.
And you've tried many
Yes,
medications.
he tried like all variants of antidepressants, beta blockers, anti-epileptics, verapamil, everything. So all kind of, even Botox, it's still effective, but about 20%. So.
And at present, would you say how satisfied are you with the treatment?
So he currently follows like an alternative medicine. He puts ice on his head. He uses cold packs, and he uses a bandage, a very tight bandage. In addition, he takes paracetamol, Stabilin. He puts a pain relieving gel, and he tried CGRP as well, and it was effective. But still, he's not completely satisfied. He still cannot live like a normal life.
Are you ever entirely and completely pain-free?
يعني في أوقات بتبقى completely مع
So like without medication, he would always have headache, always have headache, never pain-free, 24 hours. But with using these like medicine and the ice, he can control it, he can make the pain less. Sometimes he's pain-free, but it's not a normal life still.
If he doesn't treat his headaches, are they constant or do they fluctuate?
يعني بالنسبة لي الصداع بيجي بشكل غريب جدا، ان هو بيبقى موجود 24 ساعة. بيبقى عندي نيرف دايما موجود عندي هنا بيضرب على طول، وبعدين يهجم عليا صداع ويقعد يعمل اتاك لحد ما يجيبني لحد اخر درجة وينيمني على السرير.
Okay. So you just said that it's there 24 hours. It keeps coming in like sort of pulses.
Where part of your head do you feel the headaches in?
Here. And the nerve is يعني في العصب نفسه. الدكتور يعني هو بيبتدي في العصب أي حتة في المنطقة دي أو هنا، دي البدايات بتاعته النقرة، وبعدين يجي يضرب على طول في أي وقت. أنا بسيطر عليه بشكل دائم، يعني 15 سنة سيطر عليه.
These are it's like nerve pain that he feels coming from the back and mostly on that side of the head.
Any ringing in your ears, or do you hear noises in your ears?
في وش في ودني، وش مستمر في ودني. يعني هو السمع عندي ضعف لحد كبير، النظر عندي نظر للإضاءة ضعف.
Yes, he feels.
When you wake up in the morning, before you get out of bed, do you have a headache?
أول ما بتصحى الصبح هل بيبقى فيه صداع؟
الصداع بيصحيني في
وانت لسه وانت لسه راقد يعني.
اوكي، وانا نايم بصحى عندي صداع، يعني بصحى اقوم اجري عندي صداع.
Yes, he wakes up with a headache.
في وسط الليل، ولما اصحى حتى لو اخذت مسكنات اصحى تاني عندي صداع تاني ما بروحش. في حين انا مخفض المسكنات خالص، بنزل بنادول عادي.
Speaking about analgesic use, that he even if he uses an analgesic and he sleeps, he would still wake up with it.
Does your neck hurt?
رقبتك بتوجعك؟
مستمر.
Yeah, continuously.
النقطة إن مش بيجي لي مثلا فترات كل يومين أو كل 3 أيام، لا 24 ساعة بسيطر عليه بشكل كامل، يعني عن طريق 15 إزازة مياه متلجة، عن طريق زي جل متلج، يعني هنا جل.
Right, he's explaining that he does a lot of local things like applying cold things and applying a tight band to get relief.
Gel. And this 24 hour لو ما عملتش كده الصداع بيجي لي، ما هيش فكره نوبة صداع عاديه، يعني انا عشت الموضوع ده وانا صغير، صداع العادي ده مش صداع عادي.
In the past when he was young he used to have episodes of headache, But he says for a very long time it's been a continuous 24/7 thing. Do you want?
Since age 15, daily, sorry, continuous headache.
يعني
Not
بقالك
a
قد
single
ايه
day without
مستمر؟ الصداع
headache
بقاله
since
قد ايه
age
مستمر ما
15.
بيقفش؟
فندم
بقاله قد ايه مستمر
he-
ما بيقفش الصداع؟
20 سنة.
He says 20 years بس 20 years يعني 20 سنة مستمر 24 ساعة؟
هو ابتدى معايا مستمر انك تاخد مسكنات بشكل شديد جدا بسبب ان انا عندي ستريس في الشغل بشكل كبير، اني رئيس لشركه صناعيه فستريس عالي جدا فباخد مسكنات عاليه جدا.
Okay, so
كويس.
he was stressed.
بعد
he had
كده
a lot
ابتدى
of
ما
headaches.
يسيبنيش.
He started overusing medications, analgesics, and then it turned into chronic. And that's in the range of 15 to 20 years ago.
فندم بالنسبة يعني نقطة مهمة بالنسبة لحياتي كده في خلال شهرين فاتت عدت، إن الأدوية كلها طبعا اللي أخدتها ما فيش حاجة نفعت معايا خالص، بس حالة ال 24 ساعة المستمرة دي قدرت أفكر إن أنا أوقفها بطريقة إن أنا حطيت مخدر موضعي على أماكن الأعصاب دي.
Yeah. He sometimes
بينج.
puts local anesthesia on his head to relieve the local anesthetics on the scalp. He had several occipital nerve blocks, Botox injections, and they help him, but never 100%. That's always his problem. And he recently, as he was saying, he started CGRP antagonists in the past 3 months. He's found some relief, but again, nothing is going so far as to say I'm headache free.
الصداع وقف 3 أيام يا دكتور، وقف يعني مع البنج وقف الصداع تماما، ما بقتش استخدم لا جل ولا استخدم مسكنات.
You're my average patient, and one of the things that we've looked at is the infusion of, in people like you, intravenous lidocaine, like they would do in a coronary care unit. And what we have found, that many patients with intractable headache get significant relief, and we give them a medication called mixilotine, and we've published this, open label of course, about 80% of patients with intractable headache get relief. The second thing that we've looked at recently, there is a general anesthetic called ketamine, which works at the NMD receptor, and it can be given and used as a nasal spray. And there are some patients with intractable headache in whom that seems to work quite well. Some of the other questions I had asked was, one of the people can have a chronic spinal fluid leak that transforms without a postural component. I doubt if he has it, but the 2 strategies to consider would be intravenous lidocaine or the use of ketamine. It can be given by a nasal spray, orally, or by injection. And in people who are as bad as you, we've had some very good results.
Doctor, he has another question. Why did this local anesthetic like completely stop the headache for 3 constant days for like the first time of his life when you just put the spray?
هو كان بيشرح الحتة دي، احنا ممكن بعديها نشرح المنطقة دي، ان هو رأيه في كذا حاجة ممكن تتعمل منها local anesthetics والكتابين.
Okay.
Okay, we'll have to stop here because we're running out of time.
Okay.
But thank you, Professor Peter, Professor Bulai, Professor Silberstein.
Thank you, Doctor.
We'll start the next session right away. Okay, thank you very much. Chairpersons for the next session, would they please start coming on stage? يحيى.
جميل وكويس. ازيك يا حبيبي؟ ازيك؟ امال ايه؟ ما ايه يا رضا، احنا قعدنا شهرين يا رضا وببعت لك السلام مع رضا. بص نقعد بقى، نقعد من فضلكم. يعني دي هتبقى سيشن في بعد كده في الورك شوب. هو دكتور أسامة الحقيقة سأل سؤال يعني متهيألي دلوقتي بعد ما سمعنا كل الريسيرشز دي عرفنا إجابته. هو بيقول impact of headache is it worth it؟ يعني بعتقد بعد كل الريسيرش اللي سمعناها يعني دلوقتي بقينا متأكدين إن يعني محتاجين ريسيرشز تاني وتالت ورابع بالنسبة للهيدك. طبعا كل الريسيرش اللي اتقالت كانت تقريبا اباوت عن الميجرين. نرجع دلوقتي بقى ونعمل شيفت لحاجه ثانيه وهي التنشن هيدك. عندنا الاستاذه الدكتوره نهله السيد وهي استاذه سايكاتري المتميزه، هتكلمنا على التنشن هيدك one of the major diseases of psychiatry depression. فتفضلي يا نهله ونسمعك يا حبيبتي.
بشكر حضرتك على تقديمي وبشكر السادة في المؤتمر على دعوتي للمحاضرة دي. بشكر شركة لومباك على استضافتي لمناقشة موضوع التنشن headache and depression. At the beginning we want to describe there is a relation between headache and depression and where this relation starts on the biological level, on the management level, on the clinical practice level. People with migraine are more prone to have depression, and this ratio is high enough to reach 5 times more than those without migraine, which means there is a great link between depression and headaches in general, and between depression and migraine. Other predictive factors could be anxiety, depression, and sleep disturbances. The association between depression and anxiety and headache is not only on the diagnostic level, but it is more related to the frequency of headache. As much as these headache episodes are repeated more than 10 to 14 times per month, this increases the risk of having more anxiety and depression, which means it is not only that you have headache, you are more at risk for depression, but the repeated episodes of headache makes you more distressed, anxious, disabled, and this provokes symptoms of anxiety. How it affects your life? Having repeated headache means you don't have good sleep, you are not working perfectly, you are not functioning on the social level perfectly, and this predisposes to more distresses, more anxiety, and will leads you to more clinical testings, more treatments, more abuse of treatments, so it will worsen all the quality of your life. As much as the depression increases and the anxiety increases in severity, the headaches increase, which means it's a bidirectional relation. So if the headache episodes increase the depression and anxiety, and if the severity of depression and anxiety increases, this will increase the predisposition to more headaches. Other more important predictive factor is the smoking and poor sleep evidence. If you have decreased sleep level, disturbed sleep, early awakening, interrupted sleep, means that you are more prone for more headaches. Here the sleep is not the sleep which is part of the depressive symptoms, but it is an entity by its own. Where do they meet on the biological level? We have genetic predisposition for both diseases, which means if you have migraine with aura, you have the same gene which can predispose you not only for the migraine, but again for the depression. This means that you have an abnormality in a certain gene which has an expression in a certain area of the brain, and this leads to the perception of pain abnormality. Being depressed means you have decreased level of serotonin, and coming to the decreased level of serotonin, you have decreased level of analgesics, endorphins and enkephalins, and this works on the descending pain pathways which increase the perception of pain. So if you have mild or moderate headache plus depression, you perceive the pain more than normal people. So you are suffering from more pain, from more frequent attacks of pain, more complaints and more dysfunction. Again, it is not only the problem of serotonin, but you have again imbalance between dopamine and noradrenaline, and this points to the invitation of SNRIs for the treatment of headaches, not only the SSRIs as the last theories of treating migraine, which means you don't have only an abnormality in serotonin, but you have a secondary abnormality in dopamine and noradrenaline, and the imbalance between both of them will increase your headaches. That's why we use SNRIs for patients with more headache or more physical symptoms associated with depression. This is one clinical study. We've done it in Ain Shams University, and it was published in the Neuropsychiatric Electrophysiology International Journal in 2015. We studied patients with epilepsy, with comorbid migraine and depression, and the results showed that we have 20% of epileptic patients, they have migraine, and 40% of them, they have depression. And when we go back to the EEGs, those with migraine, they have centrotemporal epileptic changes, and those with depression, they have frontotemporal epileptic changes. And this was more found in younger patients, in female patients, and the onset of migraine started before the onset of depression, or after the onset. This is my case presentation, and I was lucky to have the real case before I'm presented. She's a 32-year-old woman. She has 2 children. She works as a banker, and she came to my clinic with her husband, referred from a neurologist who spent several years with her treating her repeated headaches and migraine. Actually, he referred her to my clinic because she didn't respond to multiple clusters of anti-migrainous drugs, anti-epileptic drugs, and at the end she ended with using pregabalin and sometimes naloxone. For that, they asked that you need to see a psychiatrist. Maybe these drugs need to be tolerated much better than this, or they can remove the analgesic drugs and give you other drugs. She always describes the headache that it is a continuous headache, and it is a band-like headache surrounding the head, and it has a cramp-like sensation with no definite location, but mostly starting in the back of the head with a stretch of the muscles. And she described it that it occurs in the early morning, and it affects her concentration at work. Up till that, the patient doesn't have any more complaints other than the headache, and she spends hours and hours describing the headache and the frequency and the severity and the non-response to drugs. When I started asking about other symptoms, what about your sleep? What about your appetite? What about your mood? What about your sexual functions? What about your social functions? She starts weeping and crying, and she detects that all these symptoms are affected. Here is the question: are they affected secondary to the headaches? Is it the emotional distress from the repeated severe headaches? Or is it a comorbidity between headache, migraine, and depression? Or is it the depression encompassing all these symptoms together, and the headache is one of the symptoms of depression? To answer this question, you need to understand which started first, what's the relation between stress and the attacks of headache. Fortunately, she said that she has stress in her marital life, and she has another stress to balance the effort between her marital life and her working in the bank. And all the time she is overloaded, she's under stress with some financial hardships, with some marital problems between her and her husband. And on top of this, she started to complain. The first complaint was the sleep disturbance. And this sleep means that she has difficulty to fall asleep. She has sometimes interrupted sleep and with early awakening. This is one of the major symptoms of depression. She said that these symptoms have a peak every year at a certain time, which means she has repeated attacks, usually starts at October and November, and it's worsened during premenstrual periods, which means you have definite periodic course. Secondary to this, she has sad mood, she has decreased appetite, she lost most of her weight, and she is coming less and less concentrating in her work, which indulged her with more problems with her colleagues. We can go here to if depression can encompass the headache within it or not. If we are speaking about depression, we are speaking about three domains of symptoms. We have emotional symptoms, depression, irritability, sadness, guilt feelings. We have physical symptoms. You can complain during depression from pains all over the body, and you can define it if it is related to depression or not if you have multiple systems and multiple symptoms. If you have complaints in the nervous system, in the GIT system, in the cardiac system, in the respiratory system, in the musculoskeletal system, so this is not localized to a certain system, so it is a psychiatric or a psychic complaint. You can complain of headaches, of blurring of vision, of dryness of the mouth, of increased heart rate, of shortness of breath, of nausea, or heartburns after eating, of fatigability and pains all over the body, of spastic colon, of amenorrhea and disturbed menstrual cycles. All this can be referred to depression. Moreover, which is a very important factor, is the cognitive symptoms, which means if you are a student, if you are a banker, if you are someone who has to be performing all the time on the perfect level in his work, and you have some abnormalities in concentration, in attention, in memory, this will affect on the long run your performance. I'm presenting this slide not only to say that our drug for today, which is Brentilex, improves depression, but only to say that in order to assess your patient, you need to have some skills. These scales can assess the different domains of presenting symptoms in depression, which is one like the MADRS. It presents different symptoms in the emotional scope, in the cognitive scope, in the physical scope. You need to do this assessment all over during treating your patient, because at some time you would start with that one drug. If you want to increase the dose, to change the drug, to add other drugs, you couldn't do this without assessment of the improvement or disimprovement of the patient. Brintellix, by its own, it can improve all these domains of symptoms independently. And this can be done on 2 levels, either if you are using the 10 milligram level or the 20 milligram level. And this is a study which was done in comparison with the placebo level. What is the cognitive dysfunction in depression, which is an important domain? You find the patient at the beginning complaining of problems in attention. Problems in attention means it is difficult for me to focus my attention on a certain entity, which means I feel my brain is confused. I feel it foggy. It's difficult to point to some issue and to study it in details. The next issue is, sorry, we have to go back to this. The second issue is feeling that I'm slow. I'm slow in performing in the same work that I used to do it in a shorter time. I go to my office, I have some files, I used to do it in 2 hours, now it's taking 2 days. Next point, I'm losing my memory. I couldn't concentrate well and remember things that I should do it every day. So usually I forget some things, I forget some phone calls, I forget some important issues to be done today. The last point is I find it difficult to do multitasks, and every one of us is doing multitask. You drive, you're thinking of something else, you're writing something, you're working at home, you're thinking of some work issues, some home issues, and you have to perform well on all these levels. You find it difficult to concentrate on every this, and you find it difficult to take decisions, to do plans for the future. The next point is that depression and cognitive dysfunctions goes parallel together, not only during the episode of depression, but even if the depression improves, you still have some cognitive impairment, which means that you don't suffer from problem of attention, concentration, and memory because you are in the acute depressive episode, but even after the depression improves and you are in relapse, in remission, you still have the liability to have some cognitive impairment. What is the percentage of both of them? During the acute episode, 94% of the time you have cognitive impairment. After improvement, 44% of the time you have cognitive impairment, which means that you don't need to just improve the patient on the symptom level of depression, the mood changes, the guilt feeling, the physical symptoms, but how he is going to go back to his work, how he is going to go back to his performance level. And this is very crucial when you are dealing with someone who is working as a manager, as a banker, as a student in critical stages. On the biological level, again, we have some correlations between the depression and the cognitive impairment. This goes with the hippocampal atrophy, because some monoamines are related to the cognitive impairment rather than related to depression. This is not only the serotonin, but we have the serotonin and the noradrenaline and dopamine, and we have hippocampal atrophy. I'm presenting the slides to show that other symptoms or other comorbidities can be found with depression, like mild cognitive impairment, the substance abuse, and even the effect of drugs we are giving, mainly the psychotropic drugs. This is one of the very important tests used to assess the cognitive impairment, called the digital simple substitution, which you need to concentrate very well and to do some plans and judgment and working memory. Unless you can do this, you still have symptoms of cognitive impairment. Vortexine by itself in 3 studies with using 3 different levels of cognitive tests shows improvement on the cognitive level at 10 and 20 milligram apart from the treatment of depression by itself. This slide is important to show that the improvement within depression starts from the first week, and that the effect of the 10 and 20 milligram starts to separate from 2 to 4 weeks, which means you can assess your patient starting from 2nd week, and you decide to complete on the same drug, increasing the dose from 10 to 20 milligrams. This slide shows that the effect of vortioxine on cognition is not only because the depression improved, but it is a direct effect by itself, and let me show its effect on the neurotransmitter. We have some non-pharmacological treatments for depression, like the cognitive behavioral therapy, decreasing the level of stress and the response to stress, or decreasing the level of anxiety by relaxation mechanisms and by feedback. We have different treatments for depression, starting from 1950s, which is the tricyclic antidepressants. They increase the noradrenaline, but they have the anticholinergic side effect. SSRIs, reuptake inhibitors for serotonin, but with more side effects again than the SNRIs by the early 90s, agomelatine, and the vortioxine coming in the 20s. Let me show the difference between both of them. If you are dealing with SSRIs, this works through reuptake inhibition for serotonin, one neurotransmitter and one mode of action. If you are dealing with SNRIs, we deal with two neurotransmitters, but again, reuptake inhibitor is one mode of action. If you are dealing with agomelatine, we deal on the melatonin receptors, one type of receptors, but again, one mode of action. If you are dealing with vortioxine, it has multimodal because we deal with different types of serotonergic receptors. We act as a reuptake inhibitor on the 5-HT1A, and we can act as partial agonist or antagonist on the others. Let me show this difference, it's important. This is for the for the vortioxine. It works as a reuptake inhibitor for serotonin and partial antagonist for the 5-HT1A and antagonist for the 1D, 2,3, and 2,2. What's the difference between this? If you are giving your patient an SSRI, it works by increasing the serotonin level in the synapse by the reuptake inhibition. And this increases the GABA and decrease the glutamate. Secondly, to decrease the glutamate, you have decrease in the dopamine, noradrenaline, and acetylcholine. If this increases, you leads to emotional blunting because decreasing the dopamine leads to nihilistic effect. If you decrease the dopamine and the acetylcholine, you still have cognitive impairment secondary to the SSRIs. So this is one of the major side effects of SSRIs, that it leads to emotional blunting and again to emotional blunting and again to cognitive impairment. If we deal with vortioxine on the opposite side, we increase the serotonin, and this is by increasing the level of serotonin, you decrease the GABA and enhance the glutamate. Enhancing the glutamate level leads to increase in the dopamine, acetylcholine, noradrenaline, which means increasing the dopamine will increase the motivation part of depression and increase the cognition. The acetylcholine will improve the memory and the attention, and the noradrenaline will improve all the somatic symptoms and physical symptoms associated with depression. So this is a crucial difference between SSRIs on the normal level and Printilex on the opposite side. So it is not only an SSRI, it is an SSRI with a multimodal action. In spite of acting on the serotonin as a neurotransmitter, it enhances on the primary level other neurotransmitters, dopamine, acetylcholine, noradrenaline. Here we can find the effect of Printilex on severe depression, comparing with other SNRIs like the venlafaxine on the highest level, 225 milligrams, and we still find that the 5 and 10, 20 milligrams of vortioxine is closely related to the effect of venlafaxine, with marvelous difference about the difference in the side effects. With venlafaxine, you can have problems with hypertension, with diabetes if they are uncontrolled, with the withdrawal symptoms sometimes, and you need to increase the level to 225 milligram to get the effect on the dopamine and noradrenaline. But with the 5 milligrams and 10 milligrams in Printilex, you hit the dopamine and adrenaline on the first step. Here we are using it safely with elderly patients because you still have old patients with depression, with somatic symptoms, with cognitive problems, with post-stroke depression, and you need some safe drugs with better tolerability and without affecting the cognitive function in these patients, and with improving the somatic complaints. Depression in old patients usually comes with pseudo-dementia affecting the cognition, and with multiple somatic complaints, sometimes affecting the appetite, affecting the mobility and the function of the patient. So you need some drugs to increase the level of dopamine and noradrenaline and help in the symptoms. This is the effect of votripsine coming from 3 different studies, the CONNECT study and the FOCUS and the one on the elderly patients, comparing it with duloxetine and comparing the 2 doses of votripsine from 10 to 20 milligrams. And on the 3 scales and the 3 studies, it always improves the cognitive impairment in different domains of executive function, of attention, and of working memory. The important issue is the safety and tolerability level. Using antidepressants is important because you improve the patient's condition, but usually you have side effects in different domains. You have side effects in drug-drug interactions, because when you use these drugs with other anti-convulsive drugs as mood stabilizers, with other antipsychotics, combinations of 2 antidepressants from 2 groups, SSRIs or SNRIs, or tricyclic antidepressants, and the withdrawal symptoms, the cognitive, the sexual side effects, and overweight. Let me discuss it in details. The most important is the effect on the cytochrome P450, the different enzyme profiles, and its relation with using it with anticoagulants or antiplatelets like aspirin and warfarin. And this is important when you are giving these drugs to patients with post-stroke depression. You need to give the drug without fear that this will increase the bleeding tendency. When we use it with epileptic patients or migrainous patients, if you are prescribing with anticonvulsant drugs, again, you need to have it safe and to be sure that this will not decrease the level of the anti-epileptic drug or increase the frequency of epilepsy. When you use it in combination with other antidepressants, this will increase the plasma levels, so you need to have smaller doses. When you use it with anticonvulsant, this will decrease the Prentilux plasma level, so at this moment you need to increase the dose. This is about the discontinuation symptoms. Usually we have a problem with some SSRIs and SNRIs, mainly with paroxetine and with venlafaxine. With duloxetine, when you start it, you need more time to build up the dose, and when you stop it, you need more time to decrease the dose gradually. When I use venlafaxine or duloxetine or paroxetine for improvement of depression, I would start with 12.5, then 25, then 50 milligrams, and I build up the dose within 2 weeks. When I need to withdraw it, I'm going to withdraw it gradually over 1 or 2 months. Because when the patient improves and you start to withdraw the drugs, you have sometimes side effects more than the depressive symptoms: unsteadiness, headache, problems of sleep, sometimes problems of concentration. So you need very long time to withdraw the drugs. Fortunately, with Prentilux, you don't have this. You can stop the drug without a fear of rapid relapse, and this makes it more safe than others. With the sleep disturbance, it's important because not all antidepressants you can give it daytime and nighttime. Usually some drugs, when it affects the histamine level, it increases the sleep frequency, like mirtazapine. But here you don't have this problem because it has a placebo effect on sleep. So you can start on in the morning with 5 milligrams, or you can give it by night. It will not affect driving or studying or working. This is to show that the major side effect you can face with your patient at the beginning dose of Prentilux is nausea, and at this time you give it within a smaller dose. You can start with 5 milligrams, you can give it between meals with small food in the morning, or you can start every other day. Within 2 to 3 days, this side effect subsides by itself, and it's not a problem. The other side effects of headache, dry mouth, insomnia, or sexual dysfunction is very close to the placebo level. Using it doesn't mean that you need to have dose adjustment with patients with renal impairment or hepatic impairment, because you can give it from the start by 10 milligrams. And for the P450, you can just take care that with cytochrome P400 inhibitors, like when you would like to combine it with bupropion, you need to give a lower dose. And when you are giving it with those who are inducers like some antibiotics, some anticonvulsant, you need to add to increase the dose. And for the titration, there is no problem for discontinuation. This is the box of the Prantilex. We have 2 doses available in Egypt. We have the 10 and the 20 milligrams. Usually we start with 5 milligrams. Within 1 week you can increase it to 10, and then you can increase it to 20 single dose. You can give it by day or night because it doesn't affect sleep and it doesn't affect the cognitive function, so you can give it in the morning or in the afternoon. Thank you very much.
شكرا جزيلا. ويعني انا الحقيقه قلت حاجه غلط مكتوب هنا تنشن هيد مع الدبريشن، لكن هو طلعت كلها مع الميجرين. فيعني انا اسفه ان انا قلت حاجه في الاول غلط.
وطلع ان احنا لينا في الهيدك باع كبير، يعني جزء كبير من الهيدك part of the symptoms of depression.
بس كنا نحب نسمع بطريقه اوسع شويه عن التنشن هيدك، لان كل اللي اتقال الحقيقه كان عن الميجرين. اولا شكرا جزيلا. وزي ما انا شايفه يعني هي في دواء معين هو بيستعملوه دلوقتي، وده الريسنت 2013 باين.
احنا موجود في مصر بقاله سنتين
في الدبريشن. نفسي اسال سؤال، يعني لما بنستعمله الميجرين انتاج
وحضرتك احنا بنتكلم
يعني هو
على
في ريليشن بالنوده، لكن الميجرين بيخف.
حضرتك هيستعمل كSSRI، يعني الرول بتاعه في الميجرين او في الهيدك زي بقيه الرول بتاع الSSRI في التريتمنت اوف هيدك اند ميجرين. لكن الكيس اللي احنا بنتكلم عليها ان عندنا عيان عنده depression. One of the symptoms of depression او presenting symptom of depression is headache.
انا فاهمه ان الدبريشن جاي مع الميجرين
بالظبط. فهنا
يعني
ممكن
أنا لو استعملته لوحده
ممكن يستعمل لوحده زي بقيه الSSRIs والترايسايكليكس ما بتعالج
هيحسن لي السيمبتومز بتاعت الدبريشن، لكن هيحسن لي الميجرين.
هيحسن.
والدوز تبقى ايه؟ طب شكرا.
اعتقد يعني اساتذتنا في النيورولوجي لو كانوا هيستخدموا مثلا 10 او 20 مللي جرام، اسمع الخبره دي من حضراتكم. احنا في الدبريشن بنوصل لل 20 مللي جرام وبتبقى سيف وبيحسن كل الفيزيكال سيمبتومز الريليتد للدبريشن.
شكرا يا نهله. في اي اسئله؟ any question? thank you very much. هنقفل بقى
نقفل. احنا عندنا الغدا دلوقتي ان شاء الله في القاعه اللي جنبنا طوالي بعد الساعه 4:30 بالكتير، علشان نلحق نخلص بس الورك شوبس مهمه قوي خصوصا لزملائنا يعني الجونيورز. الورك شوب الاولاني اللي هو البريفرال تريتمنتس هيبقى هنا في القاعه دي. الورك شوب بتاع البوتوكس هيبقى في قاعه النيل اللي هي جنب الريسبشن بتاع الاوتيل. قاعه النيل اللي هي قدام الباب طوالي بتاع باب الدخول، يعني لما نخرج كده من هنا تبقى هي على اليمين. قاعه النيل هيبقى فيها بوتوكس، هنا هيبقى فيه بريفرال تريتمنتس. انا عارف ان انتوا كلكم تعبانين، واللانش في القاعه المجاوره.